Good morning, everyone. This is a departmental teaching session, but I thought since the topic is of general interest to the students, we will transmit it to the students of the Jaipur Surgical tutorial. So we have requested a senior colleague from Mahatma Gandhi Hospital, Dr. Hemant Malhotra, who is a renowned medical oncologist and director of our Shri Ram Cancer Center, to tell us about the concept and philosophy of neoadjuvant treatment in GI and HPV cancers. Dr. Hemant, please.
Thank you very much, Dr. Kapoor. Am I audible?
Yes, sir. You are audible, sir.
So I presume that you can all hear me, and we can start. Usual technical glitches to begin, but I hope everything should be fine now. So, like a pleasure and privilege for me to be part of this GI group. And talk to you about, I was told specifically to talk about neoadjuvant treatment. And today we'll speak on neoadjuvant treatment for pancreas and for stomach. Because you guys some of you are surgeons, and unless you get to your cutting and chopping quickly, you don't get your daily fix. So there are already 50 or 60 odd slides. So didn't want to take too much of your time. Maybe colorectal cancer, which is another big area where we use neoadjuvant chemotherapy, that we'll do some other time if you guys allow me to do. So, like as Dr. Kapoor said, this is our hospital, the Mahatma Gandhi Medical College Hospital in Jaipur, and this is our cancer center. And this is our, comprehensive cancer care team. All the treatment specialties, medical oncology, surgical oncology, radiation oncology, and the support facilities. Very well developed pathology department and imaging departments, including a very excellent nuclear medicine department with in-house PET-CT scan. So we have all comprehensive care facilities for patients. This is the medical oncology team again. We have 7 faculty members. We have 2 pediatric oncologists also, and we have transplant specialists also. And we're geared for all forms of chemotherapy which you can think of. So first of all, getting down to the brass tacks, what is neoadjuvant chemotherapy and what are the aims of neoadjuvant chemotherapy? Well, first and foremost is that you downstage the tumor by neoadjuvant chemotherapy. Neoadjuvant chemotherapy means some systemic treatment given before local treatment. Local treatment, are surgery, radiotherapy, or both. So if you give some systemic treatment before the local treatment, then it is known as neoadjuvant treatment or perioperative treatment.
Slides are not moving. Slides are not moving.
I'm not able to move now. Mirror name over. So I'll have to move it from there. So I can continue, right? Don't want me to start from. So we were talking about the aims of neoadjuvant chemotherapy, also known as perioperative chemotherapy. Basically, the first and the foremost aim of neoadjuvant chemotherapy or giving systemic treatment before local treatment, before surgery and or radiotherapy, is to downstage the tumor. So many times in many tumors, particularly in our country where most of our cases are stage 3, majority are stage 3, the surgeon feels or the radiation oncologist feels that the initial disease is too large to comfortably treat with local treatment, either surgery or radiation. And for chemosensitive tumors, that's a very important aspect, that the tumor has to be chemosensitive. If the response rates of chemotherapy for that tumor are say 10-20%, then obviously you don't use it in neoadjuvant setting because there is more likely of the tumor progressing rather than responding. So the first and foremost aim of giving a systemic treatment before local treatment is to downstage the tumor, make the job for the surgeon easier. Then also as a corollary to increase resection rates, to increase R0 resection rates, to get to a point where no microscopic disease is left behind during surgery. Then most of the tumors which we deal with, the major problem is later on systemic relapse, which means that at the time of the intervention, at the time of the local treatment, the patient already had micrometastatic disease. So one of the important rationales of the neoadjuvant treatment is to take care of the micrometastatic disease present at diagnosis. And micrometastatic disease means that whatever imaging modality you use as per current availability, you cannot detect these micrometastases. If you could detect that, the patient would be stage 4 and possibly local treatment would go into the background. So one of the important aims is to take care of the micrometastatic disease. And again, as a corollary to this, if you are successful in doing this and taking care of all the micrometastases, or maybe not taking of all the micrometastases, but getting it down to a level where the body immune system can eliminate the minimal residual disease left, this leads to improved progression-free survival and overall survival. And neoadjuvant treatment, when you have the tumor still in the body, is also a good way of assessing in vivo chemosensitivity. So if I give a particular regime, if I give regime A to a patient in the neoadjuvant setting, then the patient has surgery and the pathologist tells me that there is not enough, necrosis in the tumor. Then in the adjuvant setting, post-surgery, I would prefer not to use regime A, but I would go to regime B because there is likelihood that the tumor is insensitive to regime A. So the in vivo chemosensitivity test is another offshoot of neoadjuvant chemotherapy. So now let's first talk about pancreatic cancer, and as I said, we do pancreatic cancer and gastric cancer today, and colorectal cancer we'll keep for some time in the future. So Globocan 2020 data, 13 most common cancer in the world, 7th most common cause of mortality. And if you look at the incident cancer mortality over the past 2 decades, you can see pretty clearly that the mortality projections for pancreatic cancer have been gradually increasing. Most of the other cancers, other than liver cancer, the mortality has been decreasing, but sorry about that. Mortality for pancreatic cancer and also the incidence has been increasing over the years, and we really need to think about this and address this. Prognosis, as is true for most solid tumors, depends upon the stage of the disease. About half of the patients present with metastatic disease. Now, a third of the patients, about 30%, presents with regional disease, and 10% of patients present with localized disease. And the prognosis 5-year survival is directly related to that. Even for localized disease, where surgery is done, the 5-year survival is only 35%. So only 3 out of every 10 patients will survive, even if they are diagnosed with local disease. And of course, the survival is much more dismal as you progress up the stages. Now, I think my surgical colleagues would know this way more than I do. As soon as you diagnose a patient of pancreatic cancer, you divide the patient into these categories. whether the patient is resectable, whether the patient has borderline resectability. This is now recognized as a distinct category, and this is because we have some effective neoadjuvant treatment for this group of patients. And then there is the unresectable category where our intent of treatment is palliative. And the definitions of resectability, borderline resectability, locally advanced, metastatic are pretty clearly defined depending upon the size of the disease and depending upon how many vessels, veins and arteries and portal vein the tumor involves. So I won't spend time on that, and I think that is pretty much described in literature. And these are the NCCN latest guidelines. You can see again that patients who clearly defined resectable patients, borderline resectable patients, and locally advanced and metastatic patients. So our group of interest today is the borderline resectable patients, in which we the medical oncologists help the surgeon in producing a response and reducing the size of the tumor, making it easier for the surgeon. So when you plan systemic treatment for pancreatic cancer, or for that matter any solid tumor, you have to define the intent of treatment. Is it curative? Is it palliative? And it is important to do this because if the intent is curative, then you tolerate a lot more toxicity. You are a lot more aggressive. You permit a lot few delays as compared to if the patient is palliative. And you counsel the patient and the patient's relatives also that our intent is curative, be ready for some toxicity, and let's try and minimize delays. Then the nature of the treatment, is it systemic treatment, which could be chemotherapy, targeted therapy, immunotherapy, or a combination of these, or local therapy, which is surgery and or radiotherapy. Then systemic therapy could be given with the intent of in the neoadjuvant setting, which we've already talked about and which we will elaborate further today. In the adjuvant setting, after local treatment, again to take care of whatever residual disease is left. And sometimes in some tumors, we also give maintenance treatment, which is after we finish the adjuvant treatment. And these are the, just to list for you the regimes which are popular in patients of pancreatic adenocarcinoma, the patients who have locally advanced disease or borderline resectable disease. If the patient has a good performance status, then usually combination chemotherapy is used. If the patient has a poor performance status, then sometimes we give single agent gemcitabine. And again, to reiterate, how do you select the first line regime? These are few of the considerations. Most important is the performance status of the patient, the age of the patient. We would, tend to give, say, single agent neoadjuvant treatment if the patient is, say, 85 years of old age and frail. Then again, comorbid conditions which the patient has. If the patient has, say, for example, diabetes and diabetic neuropathy, then we would prefer to avoid oxaliplatin, which produces neuropathy, and so on and so forth. And then, of course, stenting is important. If the patient has significant obstructive jaundice, then we can't give any kind of chemotherapy. So a stenting procedure and its complications become important. And sometimes convenience and patient preferences, and there is a questionable role of biomarkers, which we will talk about in the subsequent slides. So this is to summarize again for a patient who is young, say less than 75, but this again is not an absolute cutoff. We have geriatric scales and scores now. Our personal choice is the Charleston's comorbidity index. So rather than chronological age, we do a Charleston score and then decide our neoadjuvant and adjuvant treatment. So if the patient is chronologically young and also scores low on the geriatric scales and good performance status, then our most aggressive regime for CA pancreas in the neoadjuvant as well as the adjuvant setting is something known as FOLFIRINOX, which is a combination of 5 drugs. The alternative is also gemcitabine, nab-paclitaxel. If the performance status is 2, then combination of gem nab-pacli becomes the #1 choice, and sometimes we need to consider single agent gemcitabine also. For patients with PS 3-4, usually chemotherapy is not given, and palliative treatment is given. For older patients, this choice is switched gem nab-pacli, which has a lot less toxicity, becomes a regime of choice if a combination chemotherapy can be given. Otherwise, single agent gemcitabine. And for advanced PS patients, then palliative care. So some quick snapshots of the landmark studies in which these regimes were established. There is this study which is comparing modified FOLFIRINOX with gem-nab-pacli. This is still an ongoing study, and preliminary data have been published, have been presented in one of the European conferences, and they're pretty equally matched. A 2-year endpoint is quite comparable, and it's difficult to choose between these two. Now, just a snapshot to tell you that neoadjuvant chemoradiotherapy is now also being assessed in locally advanced pancreatic cancers, and this may be another option for patients who have locally advanced disease or borderline resectable disease. Earlier, say a decade back, when radiotherapy was, kind of really frowned upon in abdominal malignancies, that has changed with the availability of advancement in radiation techniques and the availability of SBRT and the availability of CyberKnife. So, just to tell you that radiation in the subsequent years might be an important component. Chemoradiotherapy might be an important component of neoadjuvant treatment. This is again the same study, and a significant increase in R0 resections in the chemoradiotherapy arm, and a significant increase in median locoregional failure rates in the preoperative radiochemotherapy arm. So I think adjuvant therapy is not my brief today. So maybe in the interest of time, we can skip this. And can we see this? Yes. Okay. So why is my pointer not visible over there? Anyway. So I wish I could do the prayer.
Mouse भी नहीं चलेगा. Direct pointer. I go to that only for this house.
So my apologies. I was I kind of presumed that you could see my pointer, but anyway, I should have checked on the slide. So we're talking today about early stage. So if you have a resectable cancer which has been assessed in a multidisciplinary way, and the surgeon feels that they can achieve a R0 resection, then upfront surgery is the way to go. And depending upon what is the pathological stage of the disease, then adjuvant treatment can be planned. If the patient has borderline resectable pancreatic cancer, then the standard of care today is either neoadjuvant chemotherapy or neoadjuvant chemoradiotherapy, followed by surgery. And then again, depending upon the pathological stage and the R0, R1, R2 resection, some adjuvant treatment can be planned. For locally advanced pancreatic cancers, possibly the only option is palliative chemotherapy, and metastatic cancers, again, depending upon the performance stage of the patient and the liver functions of the patient, you decide the treatment. So, several new classes of drugs are under investigations for pancreatic cancers, and as I told you, that there is a huge unmet need in this particular malignancy, and we are very eagerly awaiting for immunotherapy agents and molecular targeted agents which can add on to the benefits of chemotherapy. So, if I were to conclude, not my talk, but the pancreatic neoadjuvant part, there is an emerging role of neoadjuvant chemotherapy and also neoadjuvant radiotherapy in the borderline resectable diseases. Uh, of course, there is an established role now of chemotherapy and maybe chemoradiotherapy in the adjuvant setting. The treatment of choice depends on the age of the patient's general condition, the associated comorbidities. Our usual frontline regimes are FOLFIRINOX or a combination of GEM and PACLI. This is used in the younger patients and more fitter patients, and this being a little more gentle is used in the more frail patients and the patients with more comorbidity. Single agent gemcitabine also remains an alternative for the older and the frail patients. Studies with newer agents are under progress, and with regards to chemotherapy, nanoliposomal irinotecan again is showing a lot of promise. And then, of course, we're waiting for immunotherapies and more targeted therapies in pancreatic cancer. Again, this we did not cover in the talk, but wish to just be aware that patients who have the BRCA1, BRCA2 mutation, oral PARP inhibitor, olaparib, may have some advantage. There are a lot of target genes which now have targetable treatments now in pancreatic cancer. And these targets should be looked for, of course, in patients who can, then subsequently afford the targeted treatment. Microsatellite instability, we kind of look for in all abdominal diseases, all abdominal tumors, because checkpoint inhibitors have a big role in patients who have microsatellite instability. And I just mentioned patients who have the BRCA1 mutation, they might be candidates for olaparib, which is a PARP inhibitor both in the maintenance setting and in the metastatic setting. Then NTRK mutations, very uncommon, less than 5%, 1 or 2%. But again, there is a targeted therapy available for patients who have this mutation. Then again, there are lots and lots of novel agents, including immunotherapeutic agents and metabolically targeted agents, which are currently under active investigations, and final results are eagerly awaited. So to move a little up north, now let's talk a little bit about esophageal gastric cancers. And I don't need to tell you the Siewert classification, but these are some of the important landmarks which I think most of us are aware of. So let's not kind of dwell too much on that. And now this is a important hard-hitting slide which I'd like you to see. The survival for esophagogastric cancers with surgery alone is pretty dismal. If you have anything more than stage 2 disease, then the 5-year survival is less than 50%. So obviously, whether you look at gastric cancers or you look at gastroesophageal cancers, the picture is pretty much similar. So it's pretty clear that something in addition to surgery is needed. And this treatment failure is primarily because of distant metastasis, also because of local recurrence. So obviously something more needs to be done. And this is the evolution of neoadjuvant and perioperative treatment from 2002 onwards. This was the first study in which a combination of cisplatin 5-FU was used upfront before surgery. and this was randomized, compared randomly to surgery alone, showed a benefit. Then we had the MAGIC trial, which was a landmark trial which changed the standard of care for patients with T2 onward disease. 3 cycles of ECF. ECF, most of you would know, is a combination of epirubicin, cisplatin, and 5-FU. 3 cycles of ECF, then surgery, and then adjuvant ECF compared to surgery alone. This was published in 2006. A positive trial. I'll show you some details of this trial subsequently. And then we had another French study in which a combination of cisplatin 5-FU, upfront surgery, and then the adjuvant setting compared to surgery alone. Then a trial of neoadjuvant carbotaxol plus radiotherapy surgery versus surgery alone. And this is the latest study, the FLOT 4/AIO study, in which 4 cycles of FLOT surgery, 4 cycles adjuvant FLOT was compared with the other effective regime, ECF or ECX, X standing for Xeloda or capecitabine, in the neoadjuvant setting, then surgery, then in the adjuvant setting. This was published in 2017, and this is a landmark trial which we will, kind of elaborate subsequently. So this was the first major, well-conducted, randomized neoadjuvant and adjuvant trial in gastric cancers done in England under the Medical Research Council, acronymized as the MAGIC trial. So the eligibility were patients of gastric cancer stage 2 and above. Gastroesophageal cancers were also included, and lower esophageal cancers were also included. Obviously, they did not, patients who had stage 4 disease were excluded, and they had to have a good performance status. So these were the 2 arms of the study, randomized, 3 cycles of perioperative ECF, then surgery, and then 3 cycles of adjuvant ECF compared to surgery alone. And this is the cases distribution, about 60 plus cases in both the arms, and pretty well, randomized and pretty well distributed. About 3/4 of the patients were gastric cancers, and a lesser number esophageal and GE junction cancers. And here are the snapshot of the results for you. This is the chemo plus surgery arm, and this is the surgery alone arm. You could see pretty clearly that the number of patients who could have curative surgery were higher in the chemoradiotherapy arm. The number of patients who on pathological testing had T1 disease, 8% versus 16%, was higher in the chemosurgery arm. And the number of patients who had N0 disease and N1 disease was again higher in the chemosurgery arm. So this was ample proof that perioperative chemotherapy leads to tumor downstaging. And if you look at the progression-free survivals and the overall survivals, you can see both are statistically significant, pretty impressive hazard ratio of 0.66 for PFS and 0.75 for overall survival. So absolute gain in 5-year survival of 13%, 23% for surgery, and 36% for chemo plus surgery, and a survival benefit of at least 4 months, 20 months versus 24 months. Then this was the French trial, pretty similar eligibility criteria and pretty similar design also, using a combination of cisplatin and continuous infusion 5-FU, 2 to 3 cycles before surgery, then surgery, and 3 to 4 cycles post-surgery in the adjuvant setting versus surgery alone. Again, 60 plus patients and pretty evenly matched. About 13, these guys, in the French study, there were a lot more gastroesophageal cancers as compared to the MAGIC study. And again, the results are pretty much the same. Significant number of R0 resections, significantly more number of T0 and T1, T2 as compared to only surgery, and significant number of N0 disease as compared to only surgery. And this is your overall survival. Again, statistically significant hazard ratio of 0.67. So absolute benefit of about 14%, 24% for surgery, and 38% for the neoadjuvant chemotherapy, surgery followed by adjuvant chemotherapy. And one of the important lessons learned from these two trials was that because of the toxicity of chemotherapy, about 10% of patients uh, could not complete their preoperative chemotherapy, and approximately half of the patients were not fit enough for postoperative chemotherapy. So these were two important take homes for the study. And even considering this, the significant number of patients who dropped out, the curves which I showed you were intention to treat curves. There was a significant benefit of neoadjuvant chemotherapies for surgery and adjuvant chemotherapy. So then we had this, landmark study published, first presented in 2017 and published in the same year, which was known as the FLOT study. Again, the inclusion criteria were here: gastric cancers or G junction cancers, T2, T3, T4, and negative, or any node positive. And they were randomized to 4 cycles of neoadjuvant FLOT, followed by surgical resection, and 4 cycles of adjuvant FLOT. And FLOT consists of a combination of 4 drugs: docetaxel, 5-FU, leucovorin, and oxaliplatin. And this was compared to, another neoadjuvant chemosurgery, adjuvant chemo arm, very popular ECF or ECX. X I told you is capecitabine or Geloda. 3 cycles of ECF or ECX, then surgery, and then same 3 cycles in the adjuvant setting. So basically comparing this chemotherapy ECF, ECX with this new 4-drug chemotherapy. And again, the cases were pretty well matched. About half of the patients in both the groups were stomach cancers, and the rest were gastroesophageal junction. Again, statistically significant difference in resection rates between the FLOT arm, 94%, versus the ECF arm, 87%. And again, a significant difference between R0 resection between the FLOT arm, 84%, and the ECF arm, 77%. So again, as was seen in the earlier trials, this particular trial did demonstrate a significant benefit of FLOT in downstaging of the tumor size and in the nodal status of the tumor size. So, kind of conclusively proving. And look at the number of patients, 350 plus patients in both the arms, that this regime, the FLOT regime, was statistically better than the older regime. Here are the Kaplan-Meier curves for you. PFS better. The red curves are for the FLOT, and the blue curves are for the ECF, ECX. And you can see that both the PFS as well as the OS is statistically significantly better with the FLOT arm. Now, of course, the question of toxicity is there. There was like statistically significant difference in diarrhea, more with the FLOT, and this is primarily because of the docetaxel which we used. And then significant difference in neutropenia, more with the FLOT arm, 51%, and significant difference in neuropathy, particularly sensory neuropathy, with the FLOT, and this is primarily because of oxaliplatin. Some other toxicities, some more with ECF, but majority of them more with FLOT. But these are, as we say in medical oncology parlance, these toxicities were pretty manageable. Treatment tolerability again was an issue for patients who completed the neoadjuvant part of the study, 91% with ECF and 90% with FLOT. Almost all the patients, 94% with ECF and 94% with FLOT, could undergo surgery. And then adjuvant chemotherapy about, again, this is important. This is something which we don't anticipate and discuss too much. Only one-third of the patients could complete the 4 cycles of adjuvant ECF. Well, about 50%, half of the patients could complete FLOT. And even despite this, you've seen the difference in the survival, which I showed you. And it was, if you look at the subgroups, when they did the subgroup analysis, patients who had T3, T4 tumors benefited with FLOT versus ECF, also T1, T2 tumors, patients who did not have nodes versus patients who had nodes, FLOT was better in both the groups. Patients who had signet cell tumors versus non-signet cell tumors, both the groups benefited with FLOT. So across subgroups, FLOT was found to be better than ECF. Now, as a result of this study, FLOT is our new gold standard for patients who need perioperative treatment, who are more than T2 in staging. 5-year projected overall survival with FLOT is about 50%, but this is only 50%. Still a lot more work needs to be done to improve survivals, both by you guys and us guys, for patients with cancer of the stomach. This is the NCCN guidelines, the latest version for patients who have local regional disease. If it is T1 disease, then the choice is surgery. If the patient has T2 or higher disease, any nodal status, then category 1 recommendation is perioperative chemotherapy. Or there are some data with perioperative chemoradiotherapy, but this is much less strong vis-a-vis perioperative chemotherapy. So, like my summary slide, all GI cancers are diagnosis need a multidisciplinary assessment. I think this is something which is very, very important, and this is something which is not done in many cancer centers. And I would not hesitate in saying that for the majority of patients, either with pancreatic cancer or gastric cancer, and we need to fix that on priority. For locally advanced disease, neoadjuvant chemotherapy, sometimes chemoradiotherapy may be considered. This holds true for both the tumors which we've talked about today, both pancreatic cancers and gastric cancers. The rationale being we need to downstage the disease, we need to increase the chance of R0 resection, and hopefully improve PFS and overall survival. Careful assessment of toxicity and response to treatment is very important, and this should be done every 2 cycles because there will be at least a quarter, if not more, of patients who will progress on your neoadjuvant treatment. So these patients have to be moved very quickly to surgery so that at least that option remains. If you don't make this 2-cycle assessment, and then it is quite possible that after 4 cycles, when you do the disease assessment, the patient, an operable patient, a potentially operable patient becomes an inoperable patient. So this really needs to be kept in mind, and a careful disease assessment needs to be done in between 2 cycles, in the middle of the neoadjuvant program, so that you can detect the non-responders. And of course, toxicity assessment, toxicity management, anticipation of toxicities, and preemption of toxicity alleviation is important so that you can continue with the neoadjuvant program and with the adjuvant program. So with that, I think I will stop, and my apologies because of time constraints possibly, and more importantly, I didn't have time to get together the colorectal neoadjuvant slides. Maybe we'll do that some other time. Thank you very much. If there are any questions, then I'll be more than happy to take this.
Students. Question?
Sir, after last time, during the patient receiving neoadjuvant chemotherapy, you should make sure the patient stays fit for surgery.
No, what I wanted to convey, maybe I didn't convey it in as clear words as I should. The response, 100% of patients do not respond to chemotherapy, right? The response rate is about 60 to 70%. So you will have 30% of patients who do not respond to chemotherapy, right? So you need to pick up this group of patients in the middle of your neoadjuvant chemotherapy program. If you plan 4 cycles of treatment, you need to do the disease assessment at 2 cycles so that you can pick up these 25-30% of patients and send them to surgery because they are not going to respond to your chemotherapy. If you do your disease assessment after 4 cycles, after finishing your full neoadjuvant chemotherapy program, then there might be some patients who are potentially operable who become inoperable. So you have to avoid and take care of that population. That's what I meant to say.
First one. What is adjuvant and what is neoadjuvant? First one. What is the difference between adjuvant and neoadjuvant?
If you can't answer that, then I just wasted my time.
Manu, what is T in plot?
कैसे? साइक्लोडेक्सिल कैसे होगा? Taxane में क्या? Taxotere. Taxotere is the name in which docetaxel is available in the US. So T stands for Taxotere. It's specifically docetaxel. We don't have data with paclitaxel. I wish we had data with paclitaxel because that's much easier to tolerate.
With the pancreatic, you mentioned the neoadjuvant therapies, FOLFIRINOX and modified FOLFIRINOX and the GEMMAP for. So these seem to be like these are structured and both of them have been found to be superior and they are being effective.
Yes, sir.
Now a lot of markers are available for pancreatic ductal adenocarcinoma. You talked recently about the stromal targeting agents. So is it possible to refine the choice of neoadjuvant therapy based on the marker profile if you're able to get tissue from the pancreas with EUSFNAs or some other modalities?
So I don't know if people who are online, if they heard Dr. Saraswat's question. Dr. Saraswat's question is that 2 regimes are pretty much accepted in the neoadjuvant setting in the pancreas. Is there a marker or is there any work going on to detect some molecular markers to further refine our neoadjuvant chemotherapy regimes? There is a lot of work going on, sir, but it is very far from being validated just now. The 2 or 3 markers which are kind of, in which there is a standard of care available. One is microsatellite instability. If the patient has MSI, then they respond beautifully to immunotherapy drugs. So both nivolumab and pembrolizumab, they are not approved in the neoadjuvant setting, but they are certainly approved and possibly better than chemotherapy in the metastatic setting, not in the adjuvant setting also, but in the metastatic setting. And PARP inhibitors have been found to increase PFS and OS, olaparib, in patients who have BRCA1 mutation. Very small number of patients, 1%, 2% have the NTRK mutation. And then again, there is an approval for, and there are 2 or 3 NTRK, anti-NTRK tyrosine kinase inhibitors, which can be used, and again, a response rate of 60 to 70%. But it's very, very rare to detect these markers.
This is primarily in the palliative setting, in the metastatic setting.
As of now, the data and the approval, no, it hasn't moved up front.
So I have a question for resectable pancreatic cancers. We have now got a study which has said that neoadjuvant might be better than upfront surgery. So is the standard of care still upfront surgery and then adjuvant, or for resectable for upfront resectable pancreatic cancers?
So my personal take on this is that the even if you have an operable pancreatic cancer or resectable pancreatic cancer, your 5-year survival is still quite dismal. And the reason for the bad 5-year survival is a distant metastasis. So these are basically, even if you have a T1 disease or a T2 disease, there is some micrometastasis already there. It's already a systemic disease. Or during surgery, we are producing some micrometastasis because we are opening up so many spaces, including vascular spaces. So if we, kind of address this, then maybe our results will be better. Results in the terms of not local recurrence, but overall survival and systemic relapse will be better if we take care of these micrometastases. So, when you have a effective regime for a tumor, it is first used, as Dr. Saraswat said, in the metastatic setting, then it moves to the adjuvant setting, and then it moves to the neoadjuvant setting. So, neoadjuvant setting for early pancreatic cancer at the moment, there are studies going on, but it is not the standard of care. But it is logical to, kind of think that there might be a benefit to neoadjuvant. I wouldn't say that there is a benefit because we don't have convincing level 1 evidence. There might be a benefit.
Because sir, currently all those studies they have included that borderline resectability. They are not still the data are not published.
Two studies.
Yeah.
I think some studies are going on.
There are two which have
But even in border,
Lancet and one more, two have been published.
two RCTs are going on for this early.
See,
Have they shown anything on the overall survival? How much improvement it will achieve?
They've shown. Same with Lancet-Oncology.
This 32% was the overall survival for.
It was actually a very remarkable difference. I shared the paper with you. This was last year in 2020, sometime end of the year. It came out.
I think we need to review those two papers, maybe in one of the meetings, because the journal platform, because yes, there is evidence emerging that it may be useful even in resectable pancreatic cancer.
the pancreatic cancer may adjuvant chemotherapy we never used to think it's a non-responsive tumor. There probably will not be any role of adjuvant, but adjuvant is now like standard of care in a very large majority of patients.
I think we have this thing about you're aware of the liquid biopsies that are being done, the microRNA profiles in the blood, and other tools which might better help to choose patients which are likely to have micrometastatic disease, and probably combining them and identifying subsets. One is all comers. Everybody who has resectable cancer gets the upfront therapy. There will be toxicity, there will be cost, but better selection might be possible if we use these newer generation tools.
Completely agree, sir.
Two questions. One is actually a kind of philosophical comment. You said that a patient who's not responding or is progressing on neoadjuvant treatment, you should operate early. But these are the patients who would do bad even after surgery. So philosophically, one approach could be that why waste surgical resource on this, continue them on chemotherapy because they are in all likelihood beyond cure. So I suppose this is just a philosophical debate.
Yeah, but like something which makes us the most uncomfortable is that potentially operable cancer becomes an inoperable cancer. So then, you decide we will not operate, that's fine. But if we make an operable cancer or a potentially operable cancer into an inoperable cancer, then the guilt is on us. And I think another corollary to what you are saying is that this group of patients is automatically selected as a bad biology disease.
Yeah, that's it.
And whatever you do, whether you do chemo or you do radiation or you do surgery, the outcomes will not be good. So we really, need to specifically look at the genetic profiling of these tumors, these particular cancers, these particular patients, come up with new things, come up with new ideas. And that's a big unmet need.
Yeah. The second was that I remember when breast neoadjuvant and adjuvant chemotherapy came, a lot of Indian medical oncologists, they were of the view that our patients cannot and do not tolerate the dosage and regime which is recommended in the West. So what about these regimes like FLOT, MAGIC,
FOLFIRINOX for pancreas. What is the Indian experience? How much is the tolerability and what is the toxicity and dropout?
So, my personal take after being in the field for 30 years is that most of the toxicities are as per what has been described in the good studies, in the large studies. And other than a very few situations, excess toxicity, say 10% in the Western population and 80% in the Indian population, that doesn't happen. But we do need to keep in mind that the hygiene level of our patients, the importance to health given to our patients, the support, local support provided to our patients. If the patient is living in a small village in, say, Bardmer, then for him to get to a medical center who understands or which understands what needs to be done, and that blood counts need to be done. If blood counts of 500, one shot of antibiotic needs to be given, or if there is diarrhea, 2000 ml of fluid needs to be given. That is a problem. So more of logistic issues than individual patient genetic issues.
Thank you very much, Dr. Hemant. Thank you very much.
Thank you very much. It's been a pleasure. Enjoyed myself. And whenever I want to reiterate with you guys one more time that we need to evaluate, discuss, assess our patients together.
Yes. सर 2015 के अंदर RCT था, सिंगल सेक्टर का RCT था, neoadjuvant chemo radiotherapy and surgery versus surgery alone in resectable pancreatic cancer. So they are terminator trial just because of the strength of the study. But I don't know. So, but some studies are showing the improved survival. We will do that.
No, it stands to logic in the sense that for so long, whatever was assumed to be resectable cancer and the surgery was done, and despite the R0 resection, the survival was only still. But despite all these articles appearing in literature, we had last month a debate between the Tata Memorial by Salesh and Dr. Sadi Sakura. Dr. Sadi Sakura was speaking in favor of in borderline that yes, neoadjuvant should be given in borderline state, while Salesh wasn't convinced. So the Tata Memorial big group of Tata Memorial is a big center. They don't follow.
It's a question of translating from evidence to standard recommendations and consensus guidelines. And
it may take some time.
The volume of evidence required, these days in many drugs in medicine, hepatology, for fatty liver disease and so on, the seminal trial is so large and so powerful done over a period of time that a single positive trial means that the drug gets approval from FDA and so on. Whereas these are relatively small sized studies and trials and evidences are coming out, but the consensus will probably evolve once larger volumes of data are accumulated. So it is not percolated down from the cutting edge to the actual practice.
And if you have a good speaker and a top expert, and you give them a debate topic, they can debate both ways.
Yeah, right? That's the thing. So that's the same thing.
Debate so you can fish out
that's what I'm saying.
Evidence.
362 patients के data पे तो है 36.7 months compared to 26.6 months.
This is like very early pancreatic cancer.
हाँ सर, early के लिए phase 3 trial जापान के अंदर हुआ था. 2013 to 2016 के patients का data they have 362 patients.
You see, it stands to logic in the sense that you will require. You see, if you are operating today, think about assuming that it is a resectable cancer, but subsequently, if you see the in retrospect that only 30% of them they survive 5 years, so 70% they succumb.
Yeah.
So that is saying. Eventually, it means the patient already had micrometastasis, but the micrometastasis load will be definitely lower as compared to as the time progresses. So if you start the neoadjuvant today, it will be more effective as compared to you start say 4 months later or 3 months later, because then those micro metastases you are not taking care of and they are progressing.
अपने कंट्री में सर एक
recurrence.
Yeah.
You have to find out when
Yeah.
you're saying 70% will recur of a 5-year time frame. Now, when are these recurrences? If they are the 3 months or they are in 6 months, then the micrometastatic disease present at the time of surgery is responsible. Now, for delayed recurrences, one will have to figure out what's going on when delayed recurrences are happening.
So, and there's another peculiar phenomena which happens in our country, sir. If you have a very good response to your neoadjuvant treatment, I mean, nobody talks about it, but a certain percentage of patients then refuse the local treatment.
Yeah, that is
So that again, it should not be a deterrent to neoadjuvant treatment. But say, for example, breast, and particularly HER2 positive breast, we have clinical CR rates in which the tumor disappears of 50% now with some regime. So patient बोलता है कि मेरे को कुछ है ही नहीं है, मैं तो नहीं कराता सर, मैं तो नहीं कराती surgery.
That is the best, that is the
More so, if you operate and biopsy shows nothing, you can sit on your head and say, why did you
Correct.
operate?
Esophagus will be the same neoadjuvant setting में.
esophagus में देखो, esophagus में तो पेशेंट आता है साहब मैं खा ही नहीं पा रहा हूँ, and once you give the therapy he becomes डॉक्टर साहब अब मैं तो इसके लिए आया था और आपने मेरा तो इलाज हो गया.
Thank you very much.
Thank you sir.
Thank you. Thank you.